Well, Nangri everybody. G'day and welcome to the race Grand Rounds. It's an exciting time where we get the opportunity to hear from experts around the world to stretch us and to add value to the work that we're doing on behalf of our community. And I certainly acknowledge the value that our Aboriginal and Torres Strait Islander people bring to the country on which we are serving. Today we have the exciting opportunity to learn from someone from another country, but from an environment that has great similarities to us. The Riverland Academy of Clinical Excellence was founded to bring the benefits of education, research and clinical improvement to the health services that we provide as a service for our community. And it is being led from the health service. Another health service has decided to do the same thing. Kaiser Permanente, one of the largest health services in the world and one of the highest quality services and most innovative, has decided that it needs likewise to have an educational mission to add value to its already high reputation and quality in service delivery. Now, we are very fortunate today to have one of the people that's been at the forefront of developing this from the inside of Kaiser Permanente, a physician, an educator, and a colleague of many of us in Australia in the way that she has added value to the work that we've been doing through the CLIC initiative. Lindsay Mazzotti, thank you very much for joining us today from a very chilly Chicago, and we look forward to hearing all about your experience from Kaiser Permanente. Nakan, and thank you.
Thank you so much for having me. Good afternoon, good evening. I'm away from home right now, and so all of my time is a bit off. So thank you so much for allowing me to speak with you tonight. I hope this is, or today, I hope this is very much a conversation. I was excited to receive the invitation and did some homework to learn more about your organization and your setting. I think there are some strong parallels, and I hope that we'll end up with some time at the end for questions. The title of my talk today is The Value of the Educational Mission for a Health Service. I'm going to talk a little bit about the value and the mission, and then I'll talk a bit about creating our new Kaiser Permanente School of Medicine, which opened in 2020, but was many years in the making. My learning objectives are here. We're going to talk about value, the benefits to the health system for investing in medical education. And I will talk a lot about our integrated model because it's very relevant to sort of what we're doing here with this emphasis on medical education and research and improvement. I am going to take just a minute. One of my favorite quotes from John F. Kennedy is that we must find time to stop and thank the people who make a difference in our lives. And this picture here in front of you, I actually had my husband dig up last night from our home computer because it's no longer on my phone. This is a meeting that we had in 2015 as part of the CLIC initiative. This was in North Carolina. And I think about this frequently because these two people, Dr. Worley and Dr. David Hirsch from Harvard, walked the grounds with me imagining a state where we would have this health system that I work in embrace a medical school, and it's real. That vision came true. So you're no doubt, you know that you're in the midst of an amazing visionary and a leader, and I'm very grateful for the time that I've spent with you, Paul. Thank you. I also did some research to understand a little bit about where you're at, your health network, the geography of your location. I did find a nice place called Lindsay Point, which was kind of inspiring. But I did want to make sure that I understood, and having traveled and lived for a bit in Australia, I know the distance appears smaller, and so understanding your setting was very important. And I think I also watched your Grand Rounds, Paul, which was lovely. So today I'm going to talk a little bit first about value and defining value both for healthcare and for medical education. I'm going to take the vantage point a bit of being an investor or a leader who is thinking about why medical education. And we'll explore some of those themes and that have come up very frequently as we were pitching this and expanding our own health education footprint within my health system. Healthcare value, simply, this makes it very simple for me, and that's how I sort of like to think, is quality over cost. And so in the setting of healthcare, we think about this as outcomes, really health outcomes, and the experience that our patients have over the cost, whether direct or indirect, within the system. And so we thought about, how do we create value for medical education? And so similarly, if you think about benefit over cost, what we're imparting through medical education in terms of benefits are the outcomes that we're giving our learners. So how well they practice, the type of care that they provide, the impact that they have on the community and the health of the people they serve. The experiences that people have in the educational model. So specifically for us, this was thinking about the people who, not just the patients, but rather the preceptors, the people who are teaching and investing their time and energy in growing this next generation of healthcare workers, physicians, nurses, et cetera. And then the benefit to the greater good or the organization. And I think that's really what many of us are doing here in this space. Again, over cost, which is real. There is an investment that must be made when you're thinking about these types of programs. They are not free. But I think generally what we're looking for is the impact of a high value investment so that the benefits far exceed the cost. I want to take just a second to talk a little bit about Kaiser Permanente if you're not familiar with our model. In the United States, we are one of the most effective models of integrated care. We are an insurance company, so essentially a prepay model with our own medical groups that contract exclusively with the hospitals and medical office buildings that are as part of our organization. And so our focus is on total health of our members and the communities that they live in. And this model looks very different than the more traditional fee-for-service model in the United States. And so as we've been looking at the incredibly high cost of our healthcare system, we've been trying to continue to grow and model this type of system. And it does have, there are other pockets of integrated care delivery, but we are the largest in the United States. We take care of 12.2 million people in 8 regions, mostly coastal, but a little bit right in the middle. That's the state of Colorado. And our Northern and Southern California regions are the greatest. So we actually have been able, over the past decades, but very much recently, we've been able to show that if you are a Californian with Kaiser Permanente, that you have exceptional health outcomes, reduced risk of stroke, reduced risk of heart disease, improved maternal health. And so when you can answer those questions and show the impact that we're having, it does get people's attention. We have over 20,000 doctors, 50,000 nurses, and it is a very, very large footprint. And that means that at some times we move quite slowly, and sometimes innovation can be very challenging. So getting to the point that we were able to begin a medical school has been actually quite a feat. And we continue to sort of bump into ourselves a bit in learning how to do this work. Our secret sauce is around preventative health, as I mentioned, relationship-centered care, collaborative practice. So very much we consider it, I'm a hospitalist, I consider my job to work with my colleagues to hold the patients and improve their health, essentially. And so it's very different than the model which I trained in an academic setting, which was a little bit more around turf battles, like not my patient, not my problem. This is all of our problem, and these are all of our patients. And we use a lot of data and a lot of technology in team-based care. So this has been, for me personally, a wonderful place to practice medicine. And it's a place that I think has the opportunity to make real change. So why do we invest in medical education? So I'll begin by saying we have a huge national footprint. So the continuum of our education model at Kaiser Permanente includes, if you take the sort of pipeline through our medical school programs, our residency training, which is postgraduate, And then our continuing medical education, it involves thousands of learners and thousands of physicians, not to mention all the other healthcare staff in our setting. So we have, in terms of that middle section, our students and our residents and fellows, we train about 6,000 physicians a year. And actually, we touch 20% of the medical schools in the United States because we provide training sites for a number of other schools. And that became something that we were looking at. It's an excellent model because it means we have a chance to share our work very broadly. And yet, I would posit that perhaps we were a little late getting to some of these residents, fellows, students, where we could have intervened earlier and actually shifted some of their thinking so that they were kind of growing up in our model, and I'll speak more about that. So if and when I'm thinking about the business case for medical education, these are sort of the key points that I'm always falling back on. So medical education helps us recruit and retain physicians and healthcare workers. It helps us actually brand and market our system and the type of care that we deliver. It actually helps improve the quality of care and health equity for our members and our communities. And again, it really does expand our mission of integrated care delivery and sharing that externally. So I'm going to walk through a few of these examples. In the United States, I actually don't know what this looks like in Australia right now, but we have a huge projected physician shortage, which I would say snuck up on us, but we saw this coming at least a decade ago, and it's probably worse from the impact of the pandemic in the United States. So our total projected shortage in just a few short years, 12 years, is somewhere between 40,000 and 125,000 physicians. And in primary care, that gap is somewhere, it's thought to be around 30,000 physicians. We know that in particular, primary care has a direct impact on the health of the patients that you serve. And so primary care in particular in our system is really the sort of keystone of all of the care that we provide and one of our most concerning projections. I don't know that the pandemic hit Australia in quite the way that it hit the United States, but we are still seeing a profound impact from what we experienced over the past several years. And so our workforce, even today, I received the resignation of a number of people who've left in the last month, and it's actually shocking the way that the numbers are changing. So people who we didn't expect to leave are leaving early, and folks who are somewhat kind of able to make decisions, many of them are taking early retirement, which is something that we actually offer, where in other places, I think physicians may be working slightly longer because their economic situation has changed. That's not been our experience internally. And so this has even potentially a worse impact on our projections that we've been following. That's kind of a negative aspect. So I like to talk about, why we need to recruit, but I really like to talk about why we retain. So we have a lot of evidence now that our physicians are obtaining a lot of joy and meaning, which is one of our key strategies for keeping people. This is just an example of one of our medical student, our longitudinal integrated clerkships. The experience that our faculty have working with our learners is extremely high. Some of the quotes, it's a great experience. I enjoy the experience. I am a better physician for the opportunity to work with a student. And this is echoed over and over. And so we try to collect this and sort of send this forward to drive our business case, actually. And then branding and marketing. You talked a little bit about at the beginning around scholarship, and we've found that our learners are out and they're taking the opportunities that they've had to do quality improvement projects, data analytics for sort of large kind of informatics projects that impact populations. They're taking these on the road and they're showing, the incredible work. I had 10 students here at the conference that I'm at right now over the past few days, and they were just a highlight in the poster session of the work that they were doing to improve health equity in the communities that we're serving for our medical school. So they're showing how great things are and really taking that name out there. I'll add that I am old and that social media is now something that I do not actually understand, but I try. And our students and residents are all over. And so they are showcasing the work. They're doing their own recruitment style from the social media aspects. And it again is really taking the name of Kaiser Permanente into a little bit of a newer generation of people who are interested, both from a patient standpoint as well as from a learner standpoint. And then last, we get the opportunity to give them a way to make a difference. And so our learners, whether students, residents, fellows, they're always looking, first of all, they're extremely interested in improving quality and health equity. And so the work that they're doing as they're taking it out and showcasing it is actually also showcasing the commitment that we have to this work and to the underserved. So those are important, right? Recruitment, retention, branding, marketing. If I'm the business person, those are the messages that I want to hear about. But I'm going to suggest, this is actually just a picture of how much the United States spends in comparison to every other country. You're somewhere in the middle at about half of the percentage share of GDP that the United States spends on healthcare. And so while I'm interested in all the great things for our organization, I think the most honorable reason that we are investing in education has to do with the future. We in the United States, we have to find a way to fix our nation's healthcare system or we're going to bankrupt ourselves. And so this model that we have is very unique. And I do think that education is a key way that we're sharing that. Again, if value is quality over cost, then we want to drive that value up. So I'm going to give you two somewhat facetious concepts to chew on a bit, which these are kind of ideas that I love because when you talk about them, people they get it, right? So how do we fix our healthcare system? Well, there's two things. One is we need to grow our students, our future doctors, in an environment that's best suited for their future practice. So I don't know how much skiing goes on in Australia, but this is a picture of a ski hill in Kansas, which is known for its prairie flatness. And this is actually a ski resort that was built on top of a former garbage dump. So there are no mountains. It's really a very small hill. And I would posit that, like skiing, if I wanted to create the knowledge, skills, and attitudes of the most impressive Olympic downhill skier, I probably would not put them on this garbage dump ski resort, Kansas, but rather, right, I want to grow them in the environment best suited. So they're going to, well, they might go to Canada, but they're definitely going to be somewhere on a very steep mountain, learning all the things that they need and all the tools that they need to carry with them, right? They're not just going to go there once they're already a professional skier. And similarly, we want to raise them from birth. And so this is really part of what made us think about starting a medical school. And I would say even further back, I mean, we literally have babies born in our system. Like, how do we keep them? So like a homestead, you have to start early. So when you think about the people that you want to take over the farm, these are rarely people who've come in to just work, right? These are the people who have the farm in their blood. It's part of their responsibility. It's part of their identity. And the question that this raises is really, how early can we start thinking about raising our future generation of healthcare workers? And so, as I mentioned, ultimately, this is why the medical school made sense to us. The business case, that kind of heartstring approach to our future, and thinking about the impact of beginning at the earliest possible time. This beautiful building is our medical school in Pasadena, California, so probably 10 miles from Hollywood and the Hollywood sign. It's a gorgeous place. It is also a bed of innovation for us and a new way that we are thinking about pushing the boundaries of medical education. As I mentioned, we have 3 classes now. We started in 2020. Our first class just finished their clerkship year, which is a longitudinal integrated model, many of which you have in Australia. And they're now out embarking on kind of deciding what kind of physician they want to be. They have a couple of years before they match, and then they begin their residency training program. I know that it looks different slightly in Australia. I wouldn't recommend beginning a medical school in a pandemic, so hopefully that's not something that's something that you've passed. It was extremely challenging right about the time that our students were going out into their clinical settings. We were no longer allowed to put students in clinical settings. So it was truly kind of a shock. But I want to talk a little bit about our medical school and have a chance to share that with you. So our school is based upon 3 pillars. The school is separate and distinct from any one hospital, but kind of sits in the middle of 6 medical centers where the students do their longitudinal integrated clerkships. They belong to those hospitals for the first 2 years of their training, as well as with the patients and this, the cohort and the relationships that they derive with their clinical preceptors. Those have been incredibly powerful, very meaningful. It's really exactly what we hoped it would be when we built it. Our school has a pillar of biomedical science, a pillar of clinical science with a very strong kind of doctoring, clinical skills, and simulation work, as well as a department of health system science. So we were the first medical school in the United States to have a department of health system science. You'll notice that there are no departments that are based on a clinical specialty or silo. Those exist in the clinical setting, but not necessarily within the school. So clinical science is our largest department by far, incorporating all of the physicians who are faculty at the externally within our system. And then health system science is really, it's about population health, health policy, public health, quality improvement, patient safety, all of these movements. If you've been following this literature, and I'm actually at a health system science summit right now in Chicago, this work is really about thinking about how to impart systems citizenship or systems thinking on our learners. And this is what we do best, and it's what we need to capitalize on as we're training not just our students here, but also taking how we're training our students and bringing that into our graduate medical education space. There's a huge influence here now, especially with equity and inclusion and diversity, and with health equity. And I would argue that they are embedded. They should really be together. They are not distinct, but that's a huge mission of our medical school. Several things I said we've been really innovating on with this early clinical immersion, our longitudinal integrated clerkships. We're the second all LIC school in the United States and the first school to begin, the second school to begin in an all LIC model. There are 2 other schools in the United States that are all LIC, and hopefully more to come. The design of our curriculum is very much, it's intentionally spiraled, it's developmental. The students kind of weave through everything so that it comes together rather than sort of a preclinical and then a clinical content where you sort of have a barrier to learning how to apply the things that you learned in a classroom setting. We have a very strong coaching and well-being program, which I think for our learners today is just critical, that they're able to, that we first of all have support for learners who are coming with disadvantaged backgrounds or who have, are first in their family to be in college and in medical school, as well as just a chance to ensure that they are not developing some of the cynicism and burnout that we're seeing in some of our older colleagues. And then I spoke about our mission around EI&D. So I'm going to close here with just some of the lessons that we've learned. And I'm sure that this is very similar to the lessons that you're learning on your journey. Building and innovating is really fun. It can be very, very exhausting. We have found a real need to find the right people who are willing to take the journey, willing to take the risk, and who have a little bit of that extra activation energy to tackle a startup environment where there's a lot of uncertainty and we're kind of building as we go. And that's not for everyone, actually. We've already found a few people that was not for. We've learned to work within the parameters of accreditation and licensure. So we bump frequently into things that we just can't do yet. And then we have to come around and try to figure out how do we stay contained within these walls, but really push the envelope in terms of innovation. One example is that we really wanted our school to begin as a 3-year school. Our students have no debt. Their tuition is paid for by our health system, which is extremely novel. But we thought that they would be able, especially for our primary care docs, to get out into practice much faster. And for the United States, it was almost unimaginable to begin a school in a 3-year model at the beginning. So that's on hold. And hopefully 2 years or so down the road, when we finish our accreditation, we'll be able to proceed with that route. We found that our patients were very key to our success. Soliciting the feedback of the community that we were in was very important. And then selling and engaging our community on having a medical school and why that was helpful to them was important. So our students are always out. They have service learning clinics. They're very much embedded in improvement within the community, not just in our health system, which for you, that may be one and the same. For us, our health system sits in communities, but it only contains some of the people in that community. And so that was very important. When we developed this work, we created new roles for faculty that were folks who traditionally were only in patient care delivery, and carving out time that took them out of direct patient care delivery was not the most favorably, it was not easy, both to find a career route for them that looked different than the traditional model within Permanente medicine, as well as taking them out of practice meant finding people to backfill that work. And so it was really important as we were thinking about
I can see that Lindsay is just frozen, so we'll just wait and see if she can reconnect. So people will just hold on for a minute. One of the challenges of having an international grand round.
Paul, I have to leave at 1:30 in 3 minutes' time, but I would be interested to know, Lindsay's been talking about business practices around some of this stuff, and she mentioned that one of the measures of the success of the program was health outcomes, and I wondered how they're measuring health outcomes. Especially, yeah, thanks. Especially the kind of outcomes that are really difficult to measure, the admissions that have been prevented, or those kind of things. I'd be really interested, and if you can ask that, I'll look it up later.
Thanks. Looks as though she's coming back, so thank you.
All right. Can you hear me now?
Welcome back, Lindsay. Yes, yes, we've all stayed on, and we recognise the difficulties of an international venue. So if you wanted to share that last slide that you were on again, that would be fabulous.
Great, it's coming back. Okay, can you see it?
That's right. And you were just talking about the fact that you need to sell it to faculty because it's a different career path. I think you just finished there.
Great. I'll finish these last few points and then I'll open it for questions.
Right.
I mentioned earlier that our learners are giving back, explicitly selling and sharing with how they are providing higher quality care, prevention. We're measuring patient satisfaction and providing that back to the health system. And in that way, really demonstrating the ongoing mutual benefit for the system. And then, it has required us to think differently. I think that our system has imagined a way that we do things. We have visiting students, we have residents, but not in all specialties. And we've had to shift the way our leaders are thinking about medical education intentionally, deliberately, constantly. And I would say I had a great experience today where we're going through a new selection process for a CEO, and several of my faculty composed a letter describing why medical education is important and why the candidates who are coming in for our CEO model should should engage in the work and trying to draw out their vision. So I'm seeing these strategies now echoed in really our frontline doctors who are saying, we want this, we want more of this. How are you, leader, going to help us get here, because this has value to us as our healthcare providers. So I will close with one of my favorite quotes by Nelson Mandela. This just says, education is the most powerful weapon we can use to change the world. And I truly believe that. I also think that working in education is a joy. Working in medicine is a privilege. And adding to that, just, being in an environment of learning and growing and thinking about our next generation of leaders and physicians is just, it's the perfect spot, at least for me. So thank you very much for having me. I hope that was helpful as an overview, and I'm happy to take any questions.
Thank you so much, Lindsay. And to people who are on the call synchronously, please feel free to stay on. We will stay connected for a short time because of that interruption. If you have to leave for other work, then please view it later. But Day Parkhurst, you had a question. And put hands up if you have other questions, please. Thanks. So I can see them.
Thanks, Paul. I've got to run in a minute because I've got another meeting, but I was really interested to ask you, you talked about the importance of a business framework, and you also mentioned how one of the outcomes is improved healthcare outcomes. And I wondered how you measure that in a business sense, because I don't know what the measures are that we can use to prove the value of what we do.
It's a great question, and it's actually one of our research strategies that we're just trying to operationalize. So we have a closed electronic healthcare system, which means that we can pull data looking at practice patterns and differences in health outcomes for preceptor, people who teach versus people who don't. That's an interesting question to ask. We can look at, in some ways, we can look at patients who are attached to students and see if there's any health outcomes that are improved there. And then those are harder to answer. So things that we've done to look at that have been, we're doing work called, we're calling them legacy projects, but we're embedding the students into specific modules and having them improve the quality outcomes in those modules. So colorectal cancer screening, cervical cancer screening, hypertension management. The students are working at a system level to try to show the work that they can do to give back to the system. And so those are smaller measurements, but they're very important stories to the chiefs of those departments and to the smaller office buildings where the students are doing that work for those patients. I hope that helps.
Thank you so much.
Mm-hmm.
While other people are thinking of their questions, Lindsay, a question from me. You mentioned that one of the things you're getting the students to do is to be active outside of your business, outside of the Kaiser Permanente business. How do you convince a business to invest in places that don't bring necessarily a business return straight away, and in other health services that may be adjacent to yours or other parts of the community?
A great question. I think there's two answers there. One is that we are a model based on membership, and our membership is driven by both commercial and sort of private pay. So we have dollars that our seniors can, our Medicare system insurance plan can choose Kaiser Permanente. So if you're working with patients in the community and they hit a certain age, they may decide to come to be part of that model. I think similarly, people who are on the cusp of employment or switching jobs may be able to make those decisions later. So in an actual, if you're impacting patients directly and giving some idea that this is reputationally a great place and they're having a great experience, that might actually drive membership growth for us down the road. I think more aspirationally, we give a ton of money back to the communities because part of our mission for Kaiser Permanente is to improve the care of our members and the communities they live in. So we have an entire arm as a nonprofit that's a community health, essentially a community benefit. And the money that we give away to the community is actually often to some of the federally qualified health centers or lower income health centers that our students are embedded in. So it is very much, it's part of the mission, and it's probably part of a business opportunity if I'm looking at it with that lens.
That's fabulous. I'm just looking to see if there are any other hands up. I can't see all the people, but my other question to you is, you've clearly changed from what could be described, say, as a passive participant in medical education that's run by other organisations to an active leader of your own educational process. Have there been any hiccups along that road? Have there been any difficulties in that?
I would say plenty. Sometimes I would say people don't know what to do with us. I have never been to a conference where someone didn't ask me why we started a medical school. And I think that traditional models of university and academic training are skeptical about a company starting a school of medicine. I think it's disruptive in a good way, but it can feel disruptive to traditions and academia. And I think that's something that has been challenging from a hiring standpoint for us to kind of overcome that perception. I think sometimes people who've been in a more established academic setting as they've come in to work with us have been at odds around some of the differences in the way that we practice. Our faculty are almost all of them are full-time clinicians, and that's very different than many of the academic settings. Things like promotion, all of those things are somewhat of a challenge to adapt some of the more academic models into our setting. So work in progress. There's a question from Lucy too, Paul. She said, I'm interested in how you broadcast the benefits to the KP stakeholders, members, patients, executives, doctors, others. This is, Lucy, I think this is a lot of my job. So we have done everything from podcasts to social media to annual reports at board of director meetings, to I feed forward all of the great news that I can find to whoever wants to listen. So I'm sure people are tired of hearing from me, whether it's chiefs or directors of medical office buildings or the CEO of Kaiser Permanente. It's very deliberate, and it's as frequent as I can get it out there.
Well, you said that one of the questions that you're asked, Lindsay, when you go to conferences is why would a health service and a corporation invest in creating its own medical school? I think we're privileged to have heard the answer to that in the presentation that you've given us, and that is that it does improve the organisation and it improves the service that you can give to particularly the most vulnerable people in your community, which aligns with those values. Thank you so much for sharing your experience and your wisdom and revealing some of the scars along the way. We now know what you look like collectively. We know where you live, and I'm sure there will be many questions and conversations that arise from this over time. In Ngarrindjeri country, the word we use for saying goodbye and we'll see you again is Nakan. So from Ngarrindjeri country to Chicago, thank you very much for your presentation to the whole of South Australia, and Nakan you later. Nakan.
Thank you so much for having me. Wonderful to see you.